So ladies and gentlemen, my name is Sharon Whiteman, and I'm part of the executive team with the Lyme Disease Association of Australia. And we're really delighted to bring Dr. Daniel Cameron to part of our series for May Lyme in 2023. We provide this as a service to all Australians, current and future, who are sick after a tick bite or have a multi-system illness that's hard to pin down, and they identify it might be Lyme or one of the associated diseases. In Australia right now, in 2023, the situation is very dire, and most medical doctors that are helping us are gradually being shut down by the regulatory bodies. So sometimes we have to dig in, and it's up to us. And this knowledge and education goes a long way in understanding and supporting patients. So the other thing I'd like to say specifically about Dr. Cameron before I introduce him is that when I was first president about 10 years ago, I reached out to him with a question. He's been so generous in helping Australia, and to this day still is. And we can't really do this without collaboration like that globally. So a little bit about Dr. Cameron's background. He graduated from University of Minnesota School of Medicine and their Department of Epidemiology. He completed residencies at both Beth Israel Medical Center and Mount Sinai in New York. Dr. Daniel Cameron has led the International Lyme and Associated Disease Society, ELADS, twice as their president. He's widely recognized as author of ELADS practice guidelines, his Lyme disease science blogs, and Inside Lyme podcast. He is an author of the book Inside Lyme, an expert's guide to science of Lyme disease. He continues to see patients in his private practice, and Dr. Cameron, God bless you for being willing to, share some of your knowledge and assist those of us here in Australia.
Thank you, Sharon. So let's begin. I'm ready to dive in because I love.
Awesome. How did you get started with Lyme? What got you down that pathway?
Well, I grew up on a farm in Minnesota, which for those in Australia, that means northern Minnesota, right next to Canada. And then I ended up in New York. And for 10 years, I kept working with geriatrics, thinking, the elderly, the psych issues, social, the chronic issues, the misunderstood, the fighting for their rights. But when I set up my practice in Mount Kisco 36 years ago, there were needs like that for kids and for adolescents, for adults. And so everything I learned for 10 years, I could borrow and use for those patients. I started with 3, but over the years, it keeps growing. And but it's all ages. I do tweens, teens, adolescents, all the way to geriatric type cases. So it's been challenging, every one of them. Also, I was always like an advocate for each one of those patients. I was always an advocate because I grew up on a farm with parents and grandparents. So that same fight I seem to find satisfying with Lyme disease patients.
Yeah, we had a brief chat just before we started, and discussing about how tough it is here in Australia, but really the whole world faces these kind of challenges in the deep recognition of what we face and what's going on with this disease.
Yeah, because in 1987, they had been talking about acute Lyme, rash. Some of them had tick bites, but not many. Some had rashes, but not many. So it took years for them to figure out that there was some connection between the ticks and Lyme. And they were looking at acute Lyme. But I already had 3 cases of chronic Lyme where they were failing treatment. And, I had plenty of time the first year in practice to really get to know them. Doxycycline was all I had. So I was quite a beginner. A lot of doctors everybody has to start somewhere. So 1990, 3 years later, there was this big paper that came out called Chronic Neurologic Lyme Disease. And Dr. Steer was one of the authors. He's known for writing the first paper on Lyme, early Lyme. But he wrote this paper, and I thought, gee, if he's going to write about that, it shouldn't be very complicated to merge acute and chronic. he was describing people sick up to 14 years. They had, fatigue as a dominant issue, the concentration, the sleep, and all the other symptoms we're going to talk about today. They were being sick up to 14 years, many of them had failed treatment, is they were being retreated. Now, what's interesting is that, about 2/3 did well, but about 1/3 relapsed. So already they were introducing the concept of relapsing. They introduced the concept in that paper that some people seem to have not eradicated their organism. So I thought by 1990, it's a matter of bada boom in New York and where he was in like Yale and Boston, is that everything we know now was already established. We had more detail, but the fundamentals were already there in 1990, well into my practice.
Wow. And so what do you think, one of the things I can't totally get a grip on is what's the foundation of the politics that seems to cross continents? It's global. I know it's really tough here. But
Well,
what do you think?
it's nobody knows for sure. I just happen to be in the epicenter. The Dr. Steer was at Yale, which is maybe an hour and a half from me. Dr. Wormser was very involved. He was the one that said chronic Lyme doesn't exist. He's like 15 minutes from me. Wormser wrote the guidelines for the Infectious Disease Society of America that said that there's no evidence that chronic Lyme disease exists as a distinct entity. He also wrote that even if they have chronic issues, it's nothing more than aches and pains of daily living. So he wrote that paper, in 2000. And so once Steer, Wormser, and some others, set acute as the main issue and kind of distance themselves from chronic, no matter who talks to their patients, they keep looking at some leaders. They're not the only ones. And so we have these leaders in this area are just not going in that direction. And they keep, coming up with tests that aren't very reliable. They keep coming up with diagnostic criteria that's not very reliable. And so they get all these mixed messages out. They do concentrate on acute, they concentrate on what's going on in the organism, but you really need to come up with a plan for somebody that's still sick. One out of three people are still sick, at least in our area. They've been sick for years. And so anything that I read and follow in Australia, we have the same problems. You can't get much closer than me. I can practically see Dr. Wormser out my back window, and I'm still dealing with the same issues.
So, but the science doesn't back up this controversy, does it? There's emerging science.
The reason I wrote the guidelines for ILADS twice was that there's plenty of literature that supports what I do and what people with chronic Lyme disease or have, what they're being treated with. And so the literature is a lot better than the public position, because the fact that chronic neurologic Lyme disease was documented, that at least 1 out of 3 people were sick years after the fact, that when the Columbia trials, like the NIH trials came along, they were sicker than depression, sicker than a lot of chronic illnesses. They were sicker than traumatic brain injury. The TBIs is what they call them. And so I find that I may quote too much some of the literature, but the literature is much closer to the facts than the quick statements that are made by some of the leaders that are out here. And so I constantly often kind of get stuck in the literature to rely on rather than these public positions that are out there.
And you have that on your website or anywhere that if somebody here listening to this now into the future would like to check up on your perspective on the global prevalence or incidence or the very papers on treating?
Yeah, whenever I read an article, including that 1990 neurologic Lyme disease, is that I write a blog, science-based blog, and put it on my website. So right now I have 600 articles that I've read, abstracted, discussed, give my perspective. And so that's all available. It's on a search bar on my website. It shows up in a lot of Google searches. A lot of times it'll say Daniel Cameron, MD. But 600 gets to be a blur if you're sick with Lyme. And you get on the internet and say, gosh, this is great, but then you push the link and you're off in some other direction. So I just finished a book where I put the highlights of the 600 blogs in one spot, in one book, in one ebook. It's called An Expert's Guide to Navigating Lyme Disease. So for those this spring spring here, I guess, in the US, who are beginning to look at the issue, is they can at least look at the 600 highlights and where it's published, what the publication says. And so even though they might look at local leaders, they can look better at the literature and see what's actually published. And the hope is that when you get a doctor who's like just beginning in our area to look at Lyme, or somebody in the family has Lyme, or internationally has Lyme, is they more quickly can index the science behind the kinds of things that I do in my practice.
What an awesome service that is, Dr. Cameron.
Thank you.
And so for, Australia has had a very persistent stance that they basically just dismiss everything. There's no evidence of Lyme disease in Australia. And, some of the stories patients report to us is that, they have a positive test, but the government says until they find it in the tick, that, even presenting with a, clinical picture and a positive blood test, it's said false positive, even from what they call in Australia, NATA accredited labs. What's the, can you comment on that, the science of that, and also the medical evidence or the medical ethics of that?
Well, there's a tremendous amount of diversity in ticks across the globe. There's a lot of diversity in Lyme. There's co-infections like Babesia, Anaplasmosis, Ehrlichia, and I could go on and on. They have 19 different organisms in ticks that the CDC has identified and the CDC's put on their website. So there's tremendous diversity, but even if you just look at Lyme, there's a lot of strains. There's different proteins on those strains. So when you develop a test for the Northeast United States that the CDC backs, like they back the Western blot tests, the ELISA tests, the certain number of bands on those tests, is they tend to be focusing on the Northeast United States cases. So whenever you go past these cases, you've got troubles finding which tick you're working with, what organism, what strain you're working with. And even here where they know what they're doing, is they find that maybe a third of people with Lyme get a positive Western blot, and that's using these strains. So in the Southern United States, they were doing the same arguments. They were fighting over what strain, what tick. And in the South, they decided that, why don't we just call it STAR-I? It's called Southern Tick-Associated Rash Illness. So that means they don't want to say it's Lyme. It looks like Lyme, sounds like Lyme, it's acute Lyme, but it just doesn't happen to have any chronic problems. And so they're relatively dismissing it. In Brazil, they have Lyme, or what looks like Lyme, sounds like Lyme, and ticks have something that looks like Lyme, but they decided, instead of calling it, Brazilian Lyme or atypical Lyme, they call it the Bajie-Yersherne syndrome, BYS. And so you find different countries coming up with different labels for what they want to call things. So I think the article you sent me decided that, they weren't going to call it Lyme disease. They were going to call it the DSCATT, something like that.
Discat, yeah,
Uh,
that's the government.
this debilitating symptom complexes attributed to ticks. So it's similar to the star eye, so that by labeling it something different is that, it's cut and divide the problems that are out there. Certainly we know, even in our area, that the tests are problematic. Only 1 out of 5 get a tick bite, maybe less than half get a rash. But whenever you say, hey, I'm going to split up and call it another category, you lose that will of science to come up with a unifying principles. You get, Australia seems to have gotten lost in jargon on that one article. Of course, that article is from an infectious disease clinic where they're popularizing that name, and which is not very helpful. And they're assuming, across the planet, that we have good tests, we have reliable tests in the Northeast, that we have a good understanding of ticks and strains, and we don't have that good in our backyard. So when they're assuming as a gold standard that the tests are good in Australia, that they can't be any better than they have here. And so when you get the tests that they have over there, I'm not a judge, I'm not a pathologist who can say how reliable those tests are. I just know ones that we have aren't very good. Also in America, they talk about clinical judgment all the time. But it seemed that paper that you sent me by the infectious disease group.
Is that the Dr. Cannon? That's psychiatry,
Yes,
actually.
now, this is the Snell paper.
Oh,
and
Snell.
Cannon in the Australian and New Zealand Journal of Psychiatry. In that particular paper, they were talking about the cases that they were seeing, and surprising how similar those cases are to what I see in my backyard, what I see here, the kinds of problems that they were seeing. There are also papers over here where they do the same thing. You go to an infectious clinic or you go to a rheumatology clinic, and they say, well, how do you know they have Lyme? Because they meet the definition of fibromyalgia, chronic fatigue, Epstein-Barr, they meet the definition of depression, anxiety. And so as soon as they have one other diagnosis, the assumption is that, well, if they have fibromyalgia, then that means they don't have Lyme. If they have depression, it means they don't have Lyme. I'm an epidemiologist, so it gets confusing because they meet both definitions, the chronic related issues to Lyme, neurologic Lyme. Man, they happen to meet the definition of fibromyalgia. So just saying that it's fibromyalgia kind of is not giving any clinical judgment a chance. In America, clinical judgments, they say it's important, but it seems like that research paper you sent me dismissed clinical judgment. It didn't give it. So it's the authors aren't with me today to discuss the topic. So I was just telling you my read on it as an epidemiologist. And so these decisions they're making are creating kind of a hole, a vacuum, where patients can't get past that type of approach, that it's got to be fibromyalgia, it can't be Lyme.
Yeah. They keep everybody siloed with different names and different opinions, and denying clinical judgment of the frontline doctor. That's leaving a whole world, basically. And we're talking about Australia, but definitely a country abandoned medically.
Well, it's in America, there's plenty of opposition to the chronic neurologic issues, the POTS, the PANS, but Australia, you don't always have another country you can go to, or other parts of the country. So it's a shame when you don't get at least a diversity of opinions, and that you're not protecting doctors, giving them the chance to use clinical judgment. Since we have to use clinical judgment here, so why not they at least give some freedom for discussion instead of cutting down discussion too quick, too early, and prematurely.
What about from a medical ethics perspective? It just surprises me that a government health department can leave their constituents sick and suffering for years, while that, 3 to 5 years is the timeline for the study on ticks. They want to find it in a tick before they validate any positive in a human.
Well, the tick validation is, since I'm not a pathologist, it's always hard to tell and judge what criteria they're using to find in a tick. It can be difficult to find it in a tick here using reagents that are made for ticks here. But the broader issue, which is the ethics, is that oftentimes the literature is richer and more complete than official positions by doctors. Like, we have over here societies that say chronic doesn't exist. Chronic Lyme doesn't exist, but recently they said, oh, well, how about if we just agree to call it post-treatment Lyme disease syndrome, post-treatment, and we're going to call it Lyme disease syndrome because we're willing to call it, we're finally recognizing it as a problem. We're going to label our patients, but we're going to assume that there's no persistent infection.
Yeah. So
it's like, just when you're ready to some jargon, some ethical type of approach where you say, hey, we're each on the same page on something, they're immediately
twist it.
Using the term only if they say there's no persistent infection. And that's sort of like shuts down debate, shuts down things, and doctors who are speaking up don't always get the liberty to say what's in the literature, what's published. In fact, that's one of the reasons that I wrote the 2 guidelines, with the boards of ILADS or ILADS, because the literature was much different than that chronic Lyme doesn't exist and it's nothing more than aches and pains of daily living. It's literature says it, but patients who are sick say it too. They beg the difference that it's a lot more than aches and pains of daily living. There's a broad range of things that can be quite debilitating. I mean, there are people who do well. I have people who do well in our area. They get treated, they do well, they get retreated, do well. I'm only discussing those that don't.
Yeah.
The ethics come back to what do you do for those? Because if you're sick, waiting for a debate, waiting for a consensus someday, waiting for a test that's kind of not so good, is that it sort of leaves you trapped. You're kind of waiting for the greater good. I guess it doesn't matter if you're not sick, but if you're sick right now in your office today, is that you still have to come up with a reasonable plan today, and then still welcome the science.
Yeah. What are the medical ethics in emerging disease situations, even if it could be perceived as an emerging disease? Doctors should be empowered ethically to clinically treat a presenting picture while the research has rapidly progressed.
There's something called equipoise, EQIPOISE, which has to do with, are there different views of the same thing? So if there's like 2 different ways of doing cardiology, like stents or open heart surgery, it got pretty close as to who was right. They both had something right about heart disease. So with Lyme is that I find that the literature, the ILADS that I did the guidelines for, doctors who are independent have one particular position, and then you have doctors who say it's not a problem, it's fine, not to worry. To me, that's equipoise, that they both have strengths and weaknesses. They both have something to offer. Those who say it's not a problem, they're obligated to try to come up with a better answer rather than leave that patient sick. So I think if we were to approach it from equipoise as ethicists, and I'm not an ethical, towards an ethical expert, but they do better if they would allow some equipoise. That is, doctors who aren't always going to be right, but can you accept diversity and in this area so that you can get patients the care they need.
I have there's a project going on right now in Australia where they're having patients who've been, and I understand the concept of it is that a recent tick bite, they want to, biopsy the rash and take the tick and then monitor the patient over an extended period of time. And I'm not privy to but my heart goes out to patients in that who may be symptomatic and developing an infection, and they're being studied for 2 years without treatment. So is there other studies like that internationally? And how could you even get ethics approval for that?
Well, they've had a Dr. Wormser, who he was one of the only ones who was able to reliably culture spirochetes, and that was if he took a lot of fluid right at the edge of the rash, and he could sometimes find culture evidence of Lyme in that rash. Of course, that didn't work if you didn't have a rash, or if you didn't catch it at the edges, if you didn't have the right technique. So it helped sometimes. They had a technique where they put ticks on the volunteers. Just say, hey, if the ticks are clean and they pick up Lyme, there must be Lyme in your body. So, it was only about 20 volunteers. One of them who had been treated, the tick actually picked up Lyme from the volunteer. And so they said, oh, well, maybe we should just have ticks on you that suck your blood, and then they'll detect whether you have Lyme in your system. So it's that, but that was published in the literature as a thought. The main thought is that it's very hard to grow any of these spirochetes. They're not plentiful. They're not quite like a COVID virus where you have endless amount of virus particles. They're very few, and they don't grow very fast. So it's hard to grow, hard to culture. And once you take an antibiotic, it seems to interfere with the division of the spirochete. And so if you take an antibiotic for a sore throat, for a cough, for something else, you kind of interfere with the tests, and you can't get a positive test anymore. So they have found that after a few weeks, you can't do what we always do, which is the culture. This type of organism doesn't lend itself very well to culturing.
So it's an outdated perspective on it.
It's always been disappointing. So but when another group says, I know what I'll do is I'll try to culture it, and I'll show that they're just really showing the culture is not very good. And therefore, if they can't find anything, they stretch the conclusion to, well, it must not be there if I can't culture it. And a lot of doctors want that culture. I would love that culture. But saying it's not there by culture that's just the nature of that organism. It doesn't culture very well.
Mm. And what about the concept that, even in a country, like I've seen a map recently of where they expect Lyme disease to be endemic in Canada, right? And it's, there's no border for ticks. There's no border for animals that carry ticks or birds that carry ticks. There could, who has time? Like, I think I asked one of our top scientists once if he felt like he's making really definitive statements around there's no Lyme in Australian ticks. We've not discovered anything. And so I asked him if he had studied a statistically significant number of those ticks, and he sort of laughed and said, well, no, because I think it was 2,000 or something, and there can be 10,000 in a bush.
Yeah, well, I write about Canada in several blogs because about 20 years ago, I was in Canada speaking in Ottawa, the capital of Canada, and the public health people were pretty insistent that there was no Lyme in Canada, that if they found one, they were just briefly, they were like immigrants coming in, and they wouldn't live in Canada. So therefore they didn't have a problem. And so that over time, like they did some cute studies, like looking at birds migrating from New York, because for some reason there was New York and Canada are right next to each other. And so is Minnesota, Wisconsin, and Michigan. They're right on the border. And for some reason, the cases stop at the border. But they looked at birds and they found like 50 million ticks, or maybe up to 200 million ticks would make it across the border every year on the on the birds, because they look at a bird and it'd be like 2 or 3 ticks per bird, and they're the kind of infected ticks that they would want. So that was a suspicion that birds are messing up the border crossing. They don't stop. So, and then they did some studies of ticks, and they found that, well, there's eggs, there's nymphs, there's an adults and larvae, so that they must be living there if they have all life cycles in those areas. So they kept finding more and more ticks that seem to have taken permanent residence in Canada. Then they've also found that, then they found that babesia, which is the really common in the Northeast, that parasite, there's a lot of cases of babesia up there also. There's Powassan. One of the first cases of Powassan, the virus that's in a tick, was from Canada, I think. That may have been the first case that was reported in the literature. So it seems like they've kind of, they're still kind of resistant at times. And then because they're running into the problems that tests aren't so good. So people tend to say, well, how about if I send it to Hygienics or some other reference lab? And so then they got in the habit of saying, well, I only want to use tests that are developed in Canada, run in Canada, which are not any better than where I live. They're not that good. And so so they tend to be very restrictive on their definition. But if you're a patient, you're the one sick, you live in Canada, they're bringing the same problems that were described in this paper by Cannon, is that you could just change the findings into Canada and you would get the exact same paper. They're having the same frustrations. They go to a clinic and the clinic says, no, they don't have Lyme. They have fibromyalgia, chronic fatigue, Epstein-Barr, depression, anxiety. That's all they have. And even that paper that you sent Cannon they said that, yes, they're getting better. The antibiotics are helping. Over half are getting better. They must have medically unexplained symptoms. They can't have Lyme, called MUS. They do that same thing here. They call it MUS, which means, yes, you got a problem. We agree it's a problem. We have a term for it. We have a label for it.
Antibiotics help.
You can go now.
Sadly, I'm Canadian born. I've been in Australia for 35 years. So it's the same situation. So we got.
Yeah, they're not any better. No. Minnesota, where I'm from, they had like the dog, wood ticks, but the deer tick have started invading Minnesota. So a lot of my friends and family from that part of the United States are starting to get bit now. So that it's not just Northeast, not just Minnesota, Wisconsin. It's more and more over. We think it's the birds are an important part of it. Oh, and then these hot climates, like Australia must have some hot areas here and there.
Yeah. Absolutely.
So in the southern US, there was a feeling that, there can't be Lyme because there's no ticks down there. But the people went down in the summer because that's when they have time off. But no self-respecting tick is going to come out and sit on a blade of grass when it's hot and dry and humid in Texas. And so they did find that there were adult ticks, but the nymphs were smart enough to stay down, close to the grass, where it was a little bit humid. And they did a study in Mississippi, which is southern United States, that said they were getting adult ticks on people, but that was only December, January, and February, where it's cool enough for a tick to take the trip up the blade of grass and wait for a victim. So yes, it's around in the southern hot, dry, humid thing, but there must be some. I've seen TV. There's some hot and dry areas in Australia.
Yeah, no, it definitely gets hot in Australia, and humid. It has all ranges of temperatures. It has Canadian like weather as well as tropical like weather. It's as larger than the US, I believe, in landmass. It's kind of like watching a comedy skit where they just can make stuff up about what ticks do and whether they develop permanent residency or whether they care where they live, whether because I think I've seen studies of bird ticks on birds from California migrating to Canada, and the same out of China as well that have ticks on them. So, I wonder how long it will take for the science to be recognized or to be accepted that, ticks they can probably take up shop or move to residency wherever they end up. And not to mention, migrating animals, deer. We had deer farms in Australia that were unsuccessful, and there's certain areas of Australia that have American deer, North American deer, could be Canadian, I'm not sure, but that just live in the bush. None of these factors are taken into consideration. We're only a migrating bird's flight away from China, which I think their prevalence is about 7.8% or something like that, the last I read.
I don't know China too well, except that, they're doing some of the studies where they look for Western blot bands. There's always a debate, how many bands you need, what's the strain they have, what's the technique they're using. And so that's why it's every country seems to go through the same uncertainty. Every bit of chaos we have in the Northeast that they've had 36 years of experience is that country by country, they say, oh, it can't be a problem. Can't be, these ticks can't be the right ones. Infections can't be the right one. And, even when you look at Babesia, that parasite, it's global, northern and southern hemisphere, eastern and western issue all over. And so at one point in our area, they said, oh, Babesia, that parasite is only on the coast. That's because Krauss has his office on it. And I always think of it, it's, that if it's convenient that your disease happens to be in your backyard, but it's really all over the place. He's written papers now that, yes, it is all over. Even you get these crazy papers out of South Africa that these African lions were eating their mates, killing them and eating them. And they caught one and they found that it had these kinds of ticks that we're talking about. And they had Babesia in the ticks. And it was written up in the literature that it might not be exactly the same tick, but the similar organism. And so even there where, we have plenty of other health problems, is that where they give doxycycline all the time, give malaria medicine all the time, is that they're not really thinking about Lyme in Africa that as much as they probably could. They have ticks all the way up in Finland, up to just miles from the what do you call it, Arctic Circle. Yep. So that's where, so they were able to exist there. And so ticks are pretty hardy. And I should mention that ticks have been around a while. There was in our area, there was in the Caribbean, there was some paleontologists that discovered some amber, where it's cute in science. You see mosquitoes and other insects.
Yeah.
But this one happened to find deer, what we call deer tick now. There's Ixodes ticks were inside the amber. So they said, well, that means is these ticks, or at least similar ticks that we have now, were around at least 12 million years.
Wow.
So they had time. We're only seeing them now, but that they've probably been part of our culture. And I think a lot of people know about that frozen man who died in the Alps.
Yeah.
Otzi, the frozen man. And so he died of a bow and arrow, in his shoulder. But the only disease he had that they could find was Lyme. And well, I guess H. pylorus later on, which gives ulcers. So the two of those common diseases we have were around at least 5,300 years. So we're still just beginning to understand it. And so all of these factoids, people have got it all figured out and try to narrow it down to the exact test, and everybody's got to have a test. Everybody's got to have a positive tick in the area.
The failure of science, isn't it? And medicine.
We're pretty green. And so I'm always a big advocate for flexibility. Even if I grumble about a doctor, they're working hard, they're writing papers, they're doing things. I'm just begging that there's a little more flexibility instead of being dismissal. So I mean, some of the best papers come from the people I've talked about today, but
Yeah.
the positions that are being taken based on their work doesn't leave much opportunity for a Lyme disease patient.
Mm. And so can we touch on testing and the controversies with testing and what's gone wrong in regards to really supporting accurate diagnosis of patients? So you've mentioned ELISA and Western blot. So, and I think there's certain, the OSPA bands
Yeah.
and stuff. Can you explain that for novice patients?
Well, there's in a tick on the ground, they have outer surface protein. That is a protein A in the tick. It's cold. It's as soon as that tick bites you, that spirochete changes to outer surface protein C. So instead of being covered with A, it's C. So then they developed a test against these proteins called an ELISA. That's one protein. But because they had big plans, they were going to do a vaccine. Everybody's going to do the vaccine. Everybody's going to get a positive ELISA from the vaccine. Is going to be wildly popular. It didn't turn out to be as good as people would like, but they decided we should do a Western blot because then you would know who had the vaccine and who had Lyme. So that's where they come up with what they call a Western blot, which looks at not just one outer surface protein, but a lot of proteins. So the IgM is the immune globulin. It's the first crack at it. You get that initially. And you got to get two out of three markers. Later on, you get IgG. And you got to get 5 out of 10. So that was all presented in 1994 in Dearborn, Michigan. And, IGeneX was there. It said, well, 2 of those 10 bands were pretty predictive of Lyme. So some other people said, no, we need 5 out of 10. All those in favor of 5 out of 10 bands say yes. And so the haves, the 5 out of 10 had it, and they don't have a Bill of Rights. Even if we need to get a better test, they have the same 1994 test with the same 5 out of 10 IgG bands, 2 out of 3 IgM bands. And so when they've been doing papers, it only picks up about 1 out of 3 cases meet that criteria. I mean, 2 out of 3 are out of luck in our area. They don't get it. So now they develop all these new tests. You keep hearing of new tests. All they have to do with the new test is have it better than the old test or as good. So all you have to do now is have a test that picks up 1 out of 3 cases to get it approved. So you get these other tests come along, they just barely make it. The big story, the headline is that for all those who don't have a positive test is you're going to have to use clinical judgment. Otherwise, they're left with drifting through the fibromyalgia, the chronic fatigue, the depression pathways. They don't get the opportunity to look at Lyme disease.
So in other words, it's tests that fail in 2/3 of cases.
They're failing on
potentially.
2/3 at a time. Once in a while you get a paper where everyone has a positive test, but that's because you couldn't get in the paper unless you had a positive test. So they say, hey, all those volunteers that have 5 out of 10 bands, you get over there and we'll write a paper up saying all of you in this group has it. And so see, they all have positive band, but that's only because they're publishing only the ones that meet that criteria. It's kind of if you just look at everybody, then that's where the tests fall apart.
Wow. And
a lot of jargon, but I just thought I always like to write and talk on the historical, where a lot of this is stuck in history. Someone made a decision years ago, and we're left from that 1994 decision on Western blots.
Yeah,
it's a long time with no change.
Yeah, 30 years, people suffering and
we're
dying.
sitting here and reading a paper in Australia where they're still messing around, writing up a paper that clinical judgment doesn't count, and that the Western blot 5 out of 10 bands count. And also, the IgM Western blot can stay positive for quite a while. But a lot of doctors in our area said, oh, no, the G is G. You got to get 5 out of 10 bands. Let's toss all the Western blot IgMs if you don't get a positive IgG. And they said that in that paper. They just dismissed anybody. It's interesting in that paper that I'm referring to by Cannon is that they were saying they don't meet the definition for acute Lyme disease. They didn't say Lyme disease, acute Lyme disease. For some reason, it was sort of, they weren't even looking for any evidence of chronic, according to the way I read the paper. It just said they didn't meet the criteria for acute disease. That seemed like I'm not sure completely why they did that way, unless they just don't have a definition for chronic.
So IgM comes up first, and then IgG can be
You
there.
get IgM first, and you, in some disease like virus, you get M, and you always get G. But when it comes to Lyme, because it's a bacteria or atypical bacteria or parasite, they have a lot of similarities to your own body. They have cell walls, cell membranes, cytokines, not cytokines, lysosome, mitochondria. And so it's hard to figure out a clean test because there's always other healthy bacteria that has the same bands. So it's hard to get a clean IgG. You get IgG, but not the ones they're looking for, not the 5 out of 10 that they decided on during that vote in 1994. So
experienced frontline practitioners know that sometimes in patients that are chronic and have a positive IgG and are still clinically symptomatic, that's persistent Lyme. Is that correct?
Well, if you get an IgG and you feel well, that's just left over. So it's just that if you are positive by IgG or even negative, like let's say we're positive by some of the other criteria, you still have to use clinical judgment on who to get treated. Because if you're well and feeling well, they hang around, those antibodies. It's, you have to decide who's sick, because there is no test to tell you when Lyme is gone. You can just say, was I exposed? But not, am I still sick? So all those who do well, you're fine. It's only those who are still sick, and there's plenty of them sick, and there are plenty of them that were showing up in that infectious disease clinic that we're talking about.
Awesome. And what about, why are clinical case studies basically dismissed in regards to affecting patient care in the doctor's office or health policy?
Well, I think in medicine is a funny place, because if you go into practice, you can use clinical judgment for a lot of things, like migraines, depression. There's no test for depression. There's no test for pain. But some diseases seem to be more controversial. So when they're more controversial, it becomes more politicized for some reason. They become like tribal. Is that, that absolutely not a problem or absolutely a problem, whereas it's probably somewhere between. For you, you need to have a problem, you got to do something. For you don't. And so it's you end up with these long-term struggles where the doctor doesn't read the literature. You read it as a patient, you read it as a leader. You read a lot of papers. I read a lot of papers. And so some of the doctors say, my tribe says it doesn't exist. Or my tribe says it always exists. It's always a problem. Everybody with one band has Lyme. And everybody has Bartonella, and everybody should have pulse therapy. I'm not a fan of pulse therapy, by the way. So therefore you end up, you can read all you want as a patient, but the doctor often is stuck with whatever their tribe says, and they can't be thinking. In fact, the tribe gets so caught up in their positions that they intimidate doctors. They go after the licenses. They question their authority. They don't let them get promoted. They can't get often in the health services type thing, because the tribe is too strong. No matter what you read, no matter what your patient needs, what they need is you can't budge. And so Lyme's and tick-borne seem to end up in that too tribal and not enough of the literature.
And the politics of that is it must be soul destroying for the, the real ethical doctors that are on the front line for the right reasons.
Right. I think that how do you get flexibility that both sides have a perspective and a position, that the paper we're talking about is that they're saying this and the tests aren't that good. They talked about, at least they talked about the patients that they're seeing are very similar to what we see. So they're documenting that in Australia, there are people who have a lot of symptoms, just on that page 982 from that paper, they said, yes, they're saying the same thing you're all saying. Fatigue, pain, headaches, weakness, nausea, sleep problems, visual disturbances. But, they also had sensory issues, which a lot of people with Lyme have sensory issues. They're sensitive to light, sound, heat, cold. I think because of their immune system is busy. They also had their illness and duration and course was varied, but many of them had chronic continuous symptoms resulting in severe physical impairment, financial and care stress, and their chronic healthcare resources. This is in Australia. And they had these patients at a high rate of emergency department presentations, admission, outpatient services. Many of them required extensive time, resources, and money. The variety of treatments were done, but it seemed like antibiotics seemed to help most of them. But since they were so sick, they went to this infectious disease clinic. So I only just point that out is that it's not like you guys are inventing, leaders in areas that at least that infectious disease article documents that the kind of problems you're talking about are the problems they're talking about, which are the problems that I'm talking about. It's a universal set of symptoms that, we didn't even get to some of the issues like, PANS, which is the neuropsych issues, or PANDAS, which means the autonomic nervous system is off. And so they're lightheaded, they're dizzy, their stomach issues, all the neuropsych is every psych issue like God created tends to turn up because of the neurotransmitters. So they can have a tsunami of rage, of depression, of crying, of despair, of obsession. So it's but in terms of, are you guys describing something doesn't exist? No, that article was great at describing how sick they are, how disabled they are, how long-term sick they are, how some of them are getting better, but not all better by the time they show there. So I think it's a great paper that way. Remember I said that papers by these leaders they're not all bad. There's things you could learn. It's more of the politics of what you can do as a doctor that gets messed up.
Conclusions that they make. What happened in science, wasn't the founding premise of science is that it should always be questioned. That's
right. I question my colleagues because it's easy to complain about the tribe that says it doesn't exist. There's not a problem. Is that I have plenty of problems with my own tribe. Remember, I said I don't like pulse therapy. I tend not to focus on alternative medicine only because there's so much to be learned and so much to do in persistent infection, so much counseling I do, support that I do, that any alternative medicine I leave to the alternative medicine doctors instead of trying to do everything. I find that, even though I use clinical judgment to treat, clinical judgment is saying, I'm not going to treat, I know they don't have it. That's clinical judgment too, where you're not going to touch that patient. And so it's how do you get what we're talking about today, what looks impossible, back to everybody back at the table, just because they're all beat up and we're all like, I can grumble about them, I can grumble about my own colleagues, is how do you get back on the same table and agree to disagree and come up with a temporary solution. That's what we need.
And so where's the hope? I mean, I know you're frontline with a lot of the science that's progressing internationally. Where's the hope for Lyme patients in Australia and globally?
Well, first of all, is that there must be enough access to doctors, whether they leave country or not, for at least they be showing up in infectious disease clinics, having been, infectious disease clinic are mainly seeing the ones that aren't working, aren't getting better. Because, when you get better, who's going to go to the infectious disease clinic? Who's going to get referred to the infectious disease clinic? So somehow people are scrambling in the United States and Canada to find doctors, no matter what the problem is. And so the hope is that these kind of discussions and get people to at least be aware that there's more to it than just you don't have a problem. And so now that sometimes it seems insurmountable in the southern United States and Canada, now in Australia, that it doesn't seem very bright. So I'm not there to see what people are doing, but I hear it's plenty of a problem, but I can certainly identify it out over here, that the same challenges, and plus doctors get beat up and I got beat up.
And what would help it? Improvements on testing? Is there innovation in testing happening around the world right now?
But right now the tests only have to be as good as the Western blot. So
that are recognized, you mean?
And the Western blot as defined by the CDC using Northeast United States strains. and they're still not very good. And so I think, yes, if they can come up with a better test, that'll straighten it out. But still, 35, 40 years later, they still haven't come up with a better test than the Western blot. That's the star, the gem. Even in that infectious disease people, they use that as the ultimate. So if that's
there are other tests, it's just that they're not approved from regulatory bodies.
Well, there's some reference labs and special labs that are out there, but they're facing the same problem everybody is that how do you know what's reliability, what's dependable, what's predictable, what's a true positive, what's a false positive. And so every specialty lab still has those challenges too, because we want labs that help us, but we certainly need a lab to tell us when people are better. If we can get one of those, then we can say, oh, you're not better yet because this test doesn't show it. We don't have that yet. So it's certainly a problem yet, but yes, if we got the better test, which I don't see right now, we'd solve a lot of these issues.
So your viewpoint is that conversations of diverse viewpoints and coming to acceptable common grounds that support patients is the best way forward?
Yeah, because I think that this type of dialogue, and plus I relied on that article just because that article is freely accessible, or I think it's freely accessible. Anyway, that article is certainly validation that there's problems in Australia that I see here. So validation is helpful. There are people that are working on getting better, getting some treatment, or they wouldn't be showing up in the clinics treated. So it's how to know that you're not alone, how to know that there are people across the world working on trying to do better than this. And so that's why everybody's shouldn't be isolated and should keep working on it. And I have plenty of people where longer treatment is helpful, or combination treatment, but it's often, if you get on with it, it's a lot simpler than it looks. Not everybody's a chronic failing treatment. And I have some of them, but get on with it certainly helps a great deal.
Awesome. And is there anything you'd like to leave people in Australia with, Dr. Cameron?
No, I thought that you did a good job of laying out the challenges that you face, but you're not alone. I face the same things here in my neighborhood. This latest book I mentioned was, An Expert's Guide to Navigating Lyme, is not to say exactly what to do, but how do you find what you need to know at your fingertips to get to the science of it, the clinical descriptions. There's 200 cases in there. And so I'm battling because I see patients, but I'm also battling because I'm right, and that type of thing. And that's 36 years later, I'm still writing.
Well, thank you, Dr. Cameron. God bless you for that.
Thank you.
And we'll go forward here in Australia and also to keep working towards what Lyme, current and future Lyme patients really need, which is effective diagnosis and treatment.
Okay, wonderful.
Thank you for your time.
Thank you. Thanks, everyone.